Good afternoon, everyone. Can everybody hear me okay? Yeah? Let's see, if we could get people to move in closer, we don't bite. And we'll get started with the session here, Living Your Best Life with Diabetes. And we'll have a little panel discussion from our all-star cast here. And I will let them introduce themselves here shortly. I'll be the moderator of the session here at the Tribal Health Summit. And for those of you who have not met previously, my name is Damon Jacobs. I'm the Diabetes Program Manager at the Haskell Indian Health Center. I'm an Oglala Lakota and have been living in Lawrence, Kansas since 2009. I've been in my current position for about 2.5 years now. And previous to that, I worked at the University of Kansas Medical Center as a biomedical researcher, so doing bench research. I studied the mechanisms of diabetes onset using a mouse model of obesity. It's very interesting. Things you learn from mice and can sometimes translate into human condition also. And like many of you, diabetes runs in my family. And I've witnessed the effects of diabetes on people close to me. It's a very real concern for our community health, obviously, and I just hope to make a little bit of difference during my lifetime and helping overcome that. I'm looking forward to this panel discussion, and I think it's going to be really valuable information to share with everybody here at the Tribal Health Summit. Just want to touch on a few areas, basically looking at diet, physical activity, any support systems that might be in place or not be in place for you, and then just a little bit on the mental or emotional aspect of dealing with a chronic disease. Let's see. So just a few numbers out there. There's 37 million Americans have diabetes, and that's 11% of our population, a little over 11%. Oh, okay. So that's 1 in 10 people, and that's a lot. And of those 37 million people, 28 million are diagnosed, and the rest of them, 8.5 million, are undiagnosed. So a lot of us don't even know we have the disease yet. Let's see, and what's even scarier is that 96 million Americans age 18 and under have pre-diabetes, or 18 and older, sorry, have pre-diabetes. So that's another round of people who will develop the disease later in life if they don't make changes to their lifestyle. American Indians and Alaska Natives have a 14.5% diabetes rate in the entire population compared to 7.4% for non-Hispanic whites. So we essentially have twice the likelihood of developing diabetes than our counterparts in the population. And diabetes is a very costly disease also. Like $327 billion are spent each year on diabetes and its complications. And basically what that translates into is each one of us who have developed diabetes will pay two to 3 times more in healthcare costs than those of us who don't have diabetes. So now we'll shift gears a little bit and have our panelists introduce themselves.
Dr. Jacobs,
yes.
Can I ask you a question?
Sure.
To you as really sounds like a preeminent researcher in this area, what are some of the theories as to why the diabetes prevalence is twice that in the native population? Are there other factors than what we think of as just like, diet and activity, factors that have to do with the colonization of indigenous diets and so forth?
So that's an excellent question. Thank you, Elizabeth. So basically, there's a new buzz term out there called social determinants of health, and basically it's an all-encompassing term that takes into account social economic status, your activity levels, your lifestyle, the foods you eat, the diet that you have access to, your income, and a few other things that are escaping me at the moment. But there are a lot of different social aspects that play into our lifestyles nowadays. And so there's really no hard evidence for a genetic component, but there is a lot of circumstantial evidence that kind of points towards it. And one of the areas of research that's coming forward is epigenetics. And essentially, epigenetics is how your environment interacts with your genetic profile and your gene expression. So your environment can have a negative effect on your gene expression. And what's also being learned about that is that can get transferred from generation to generation. So the diet and a lifestyle that our parents experienced in their lifetime, that genetic profile can get passed on to us. And so there's a lot of different things going into that question. Yeah.
Thank you, that was really helpful.
You're welcome.
It's far more complicated than just saying eat better. You're saying there's all these other possibly genetic factors.
Absolutely. Yeah.
Thank you.
You're welcome. Yes.
Just briefly, I wanted to bring out that the speaker prior to you in this room, I felt needs to be a little more sensitive because she brought up diabetes in one of her examples and what she said was, if I eat chocolate, I'm going to get diabetes, which to me is such a dangerous thing to say when you have a platform for speech and health, because we all know that's not true. And, as a diabetic myself, I've never drank alcohol. I'm 62 years old. I've always, done my best to do my speed walking.
Wow, that's great.
And it doesn't matter. I'm on Ozempic to control my diabetes. And, my mother grew up on the Kickapoo Reservation where they had to eat grease sandwiches just to stay alive. So, a lot of times, when we're, in Indian country, we don't want to be looked at as, oh, it's her fault that she has diabetes. She must drink alcohol or she must eat a lot of chocolate. Those kind of myths, are ridiculous. And especially when you have somebody in this forum who is going to bring that, something like that up. And when I mentioned it to her, I could tell she did not like it. I don't blame her, but I didn't like what she said either. So.
Yeah, definitely need to, watch how we talk about different aspects in our life. If you can eat chocolate, and we'll actually get into that a little bit with our registered dietitian about, what is appropriate in our daily lives. I can't speak for the person herself, but yeah, I appreciate your comment though. Welcome. So we will introduce our panelists now. We have, let's see, so unfortunately Maggie was not able to join us today. So we'll go on without her. But we do have Rhonda, Angela, and Matthew. You want to say?
Hi, I'm Rhonda Cully. I'm a member of the Winnebago Tribe of Nebraska.
Hi, my name is Angela Meyers. I am a registered dietitian and a certified diabetes care and education specialist. I have been working at Haskell, that's much louder. I have been working at Haskell Indian Health Center for the past about 3.5 years.
It's hard to follow up with that. My name is Matthew. I'm the director of the Diabetes Prevention Program at Prairie Band Potawatomi Nation, and I oversee our metabolic health and wellness clinic that we have there, which is prescription weight loss medications. We also, I oversee our CGM machine, our continuous glucose monitoring program also. Hold 25 certifications, master's degree in exercise science and nutrition, and also battle this daily myself. So I understand where a lot of you are coming from.
Thank you. So Rhonda, can we start with you? So I'm really curious about, you know, the emotional aspect of being told you have a chronic disease, and if you feel comfortable, would you be willing to speak on that? So what are your thoughts or emotions, you know, when you received your diagnosis? And do you have any advice on how to deal with those thoughts or emotions?
Well, I was diagnosed with diabetes at the age of 40. And frankly, I was just shocked. I'd been an athlete, softball and volleyball my entire life, and just was floored when they told me that I was diabetic. But I had all the symptoms. I had got hurt and was no longer able to participate in sports. And that's when I was diagnosed, because I hadn't changed my diet and I was no longer moving around. And diabetic reared its ugly head. And to be told that I was going to have to be put on medication. And the really scary part for me was my father had passed away from diabetes. And I wanted my kids checked immediately. I went to the far realms of it right there. I was more worried about my kids than I was about me. We started eating salads like crazy. I didn't really receive any type of education from my provider about healthy choices or anything like that. My kids rebelled, and then it just became a battle at home. But it was more just being afraid because my father had passed away from it.
Yeah, I understand completely. Yeah, like I said, diabetes runs in my family too, and I've seen it affect, you know, a couple of different generations now. And yeah, it's tough. Thank you. Appreciate that. Let's see. So, Matthew. So, as let's see, as a director of a diabetes program, what resources do you have for people who have been diagnosed with diabetes? Do you hold classes or?
That's a great question. So COVID changed a lot of things on how we ran our program. When we first, I've been there for 14 years, so how we used to run the program, we were community-based. COVID kind of shut that down, and we were worried about our population, and with that population, we wanted to do everything we could to save them and save the members of the community. So we started focusing on just a clinical approach, which has been fantastic. We've seen A1C reductions of 1.6% across the board with our CGM machines, weight loss of 3,000 pounds between 200 patients in 2 years. So what we were doing, we're doing it well. But as education-wise, we weren't able to get in a class setting. And we're starting to ramp that up now, and we're starting to get back out into the community. And how we're doing it now that once you have a diagnosis of diabetes or pre-diabetes, we're able to see you immediately within the clinic and give that education, so you don't have to be like Rhonda when the provider doesn't give you education. We are there to do that immediately once we get that phone call.
Yeah, that's great. That's really great. I think at Haskell we have a similar program going on. As soon as there's a diagnosis, there's a whole team of people that, you know, sit down and talk with our patients. And Angela is actually part of that team, and we also have I think we probably took a few notes from you guys at Prairie Band in terms of getting our CGM program up and running. So we're really ramping that up now also. So Angela, so what would be your best advice to someone that's looking to change the way they eat?
So I would say, as far as changing your eating is very individualized. It's not a one size fits all. So usually my recommendation is to kind of look at your own diet and see what areas do I think that I'm doing well and what areas do I think I need to work on. And then from the items that you think you want to work on, whether it be portion sizes or water or vegetables, kind of pick what one change can I start making today. And I usually recommend start with one and start small. Because if we try to do 10 things at once, 5 things at once, sometimes even 3 things at once, when we're busy people and we have a lot going on, it's very hard to maintain that. So if you just start small and pick one thing that you want to work on, kind of start with that, and then you can build on that. So once you get used to that one thing, then you can pick the next thing. And then 3, 6, a year, more than a year down the road, you can have made 5 to 10 changes, and it's going to be a lot more sustainable and something that you're going to be able to stick to versus trying to radically change everything overnight, which generally for most people is not going to work.
That's actually, I'm gonna piggyback on that. That's actually really good because whenever I see patients, and not only patients, but with myself, I tell them one thing is like, how do you eat an elephant? It's one bite at a time. And that's how we're gonna not fix this, right? But we're gonna slowly get you back to where you need to be, because my A1C goal is gonna be different than Rhonda's A1C goal, and Rhonda's A1C goal is gonna be different than my wife's A1C goal. So it's finding what works best for you and having that one goal, one time, one day. Mine's just a better breakfast. Wake up, I didn't eat, I didn't sleep great, my child was screaming, co-sleeping's horrible, but waking up and not getting that right sleep really puts me really hungry, and I want a chocolate in the morning, or a McDonald's breakfast. But it's about building those smart habits, those small habits that I can win, that I'm in control of.
So Angela, just follow up on that. So what does a typical treatment plan look like for you and your patients that you work with? Are there multiple visits or?
So generally, yes, I like to see people for multiple visits. Generally, the first visit is going to be the longest visit, where we would talk kind of about recommendations as far as eating well with diabetes, as far as learning about the patient. What are your food preferences? What types of foods are you eating? What types of foods do you like to eat, as well as what changes are you not going to make? I think all of those things are valuable information to know, and based on that, we can kind of individualize a plan that you feel is going to work for you. After that first visit, usually I recommend, like I said before, picking that one small thing you want to work on, maybe 2 small things if you're really ambitious and you're wanting to do that, never really any more than that. And then following up, generally trying every 3 to 4 weeks to kind of check in and see how is that goal going? Is it going well? If it's going well, do we want to build on that, or do we want to stick with that for another month and then build on it down the road?
Yeah, so that just kind of makes me think about the support systems in place and the presence or lack of support systems. Rhonda, do you have a good support system in place that might be your family, your providers, your community?
Yes, I do have a really good support system. Matt was very instrumental in helping me get started on my lowering my A1C. He gave me a really good diet plan, and I followed that religiously. My family, my son, I live with my son and his wife and their kids, and my youngest granddaughter walks me every evening like a pet. I have a stationary bike that I ride in the mornings. I had both of my knees done, thanks to the weight loss I was able to lose, being on the diet that Matt gave me. And it's just a wonderful support system that I have. My son checks in with me when I have my diabetic appointments, wants to make sure that my A1C is still going down or at least maintaining what it was. If it goes up, he's asking me what's going on. Am I, starting to slide? Am I going out to eat more? We drink water and juice. He wants to know am I dipping into Pepsi again, or, they just keep really good track of me. So I have a very good support system.
Yeah. How important do you think that is?
For me, it's holding me accountable, and I need to be held accountable.
That's great. Yeah. Yeah, I think we all need support in all different aspects of our life, and having managing a condition like this, it just you definitely need some help with that. It's not an easy thing to do. Matthew, so you run your diabetes program, and I'm sure you have a physical activity program that you implement. So what factors determine the level of physical activity for a diabetic patient? And are there methods or strategies used to help them achieve those goals?
Absolutely. So I have a great lifestyle coach, Ness, back there in the back. Say hi. She is amazing. Before she got here, what we would do is we would do boot camps and exercises and water aerobics, and then COVID hit. So, and each exercise or each individual is different. And the first thing I ask them is, what is health to you? And how do you know if you've had a good workout? Is it sweating? Is it where you can't get yourself up off the floor? Because we need to retrain the brain to say, hey, what is a good workout? What is something that I can sustain for a long time and do this for the rest of my life? Now, lifting 400 pounds off the ground was great in college, but it doesn't work well if you're 40 years old or more. Yeah. So it's knowing the individual and what their goals are.
Mm-hmm. Yep. That's excellent. Are there like national standards that say the CDC or the ADA that they put out that?
Absolutely. So the minimum of exercise comes from the CDC's 150 minutes a week, lightly, moderately, and 75 minutes vigorously per week. No, that's 15, 20, 25 minutes a day, 5 days a week, 7 days a week. Then you have great runners like our health clinic, Jay, where she gets out and runs the hills all day and does 40 miles. And that's not really what we're trying to, that's great if you can do that. But if we have a patient like me that's starting off again and hasn't touched a weight or exercise since COVID, which has been 3 years, it's going to be totally different.
Yeah, for sure. Starting small, one thing that we talk a lot about in all the different aspects of our self-management education classes is setting SMART goals. That's having a specific measurement and having a specific goal, having it being measurable, attainable, which means don't set such a high bar for yourself so that it's questionable as to whether or not you're going to get there. Set yourself up for success. And relevant, something that really means something to you, and then have it on a timeline. Just, it needs to be measurable on a timeline also. So, like in 1 month, say you just make your goal. Like I'm going to walk 3 days a week for 20 minutes each day for 1 month because I want to be healthier. That's kind of a SMART goal, and it's measurable and can hold yourself to attaining that goal. So, Angela, can you kind of speak on like the importance for healthy eating? How important are carbs, proteins, and fats? And should you cut any one of those out of your diet at all?
So carbs, protein, and fat are all important parts of our diet. None of them should be cut out. Carbohydrates, I know a lot of times with with diabetes, you will hear, oh, I shouldn't eat carbs, or, I'm trying to cut out carbs. But realistically, even for someone with diabetes, generally 40 to 50% of your diet should still be carbohydrates. Carbohydrates are our body's preferred source of energy and preferred source of fuel. So it is still a very important part of our diet, and one that we shouldn't try to cut out. Protein is also very important. Protein is involved in a lot in the body. A lot of times when we hear protein, we think muscle. Protein is the building blocks of muscle, but it's also involved with, like, hair is protein, skin is protein. Protein plays a role in hormones. So protein is something that we need in our diet. And then fat, we would need fat in our diet as well. There are some vitamins that are fat soluble. So if you take those vitamins without fat, your body's not going to absorb them as well. And then fat also provides a lot of satiety. So fat is going to help you stay full. So trying to cut out any of the carbs, protein, or fat completely is not going to be in your best interest, because we really need all of them to function as our best selves.
Yes, thank you. Thank you so much. It makes a lot of sense. You just can't cut out any of those because your body is made up of all of those elements. And if you cut out carbs, then your body starts breaking down proteins and things like that for energy sources, and that can be a bad thing also. Let's see. So, Matthew, are there... For somebody trying to start their physical program, their physical activity program, are there certain concerns that diabetics have?
Absolutely. We want to make sure that your blood sugars don't dip or spike, especially during exercise. A lot of people are really into supplements, so we want to make sure that you get checked out per your provider and have any supplement questions. We have a great dietitian that will answer all those questions. But yeah, there are some concerns. Of course, get with your provider before starting any kind of physical activity. Even if it's just walking again, getting those annual checkups just to ask your doctor.
So what can a diabetic person do to sort of learn how their body reacts when starting out a exercise program?
Well, number one is stay away from social media, as you all know. No, there's some great platforms out there. You can ask Angela, myself, any of our diabetes prevention program staff, the CDC, the ADC. There's so much that you can get from online platforms. Yes. American Diabetes Association, is it ADA? ADA.
Yeah.
Sorry, my bad.
Yeah, so it's really important that people keep an eye on their blood sugars when they're working out, especially when they're first starting out. They might not be fully aware of how their body burns that blood sugar, and it'd be really easy to send those blood sugars down. And that's hypoglycemia, and that's definitely not a good thing, right?
Especially if you're not eating carbs.
Exactly. And so one advantage to our CGM programs is that people are able to monitor their blood sugars on a real-time basis. Like within minutes of starting their exercise, they can take a quick scan and see how their blood sugars are going, and it's really an important thing to keep an eye on those blood sugars. And hopefully you don't have to do too many finger sticks, because that can get a little cumbersome. But the CGM programs that we're pushing right now are perfect for something like that. So, Rhonda, are there certain aspects of managing your diabetes that you find are most difficult? And do you find that you are getting the proper care and attention from your providers?
Oh, maybe the hardest thing for me was in the beginning, sticking to the diet plan. I wanted to rebel. I knew I could do it better on my own, but I've been doing it better on my own for the past 20 years and wasn't getting anywhere. So facing facts was probably the hardest thing. And actually talking to Matt, and he'd shoot me an email weekly asking me how I was doing. That kind of was really what I needed, that little boost of confidence. And he'd always end it with, I know you can do this, you got this. And that kind of support is something that I really needed to hear, was somebody else believed in me. And so that was probably the best thing that I got. My provider is really busy, and I only see her every 3 months, so I don't really see her very much. She just liked it that my A1C was going down, and she would just say, keep doing whatever you're doing. And I gave really a lot of credit to Matt, and she threw it back on me and saying it was whatever I was doing. So that's the kind of support that I get.
Nice.
That's really what I needed.
We
And
just-
then I joined a lot of clubs at the Elder Center out on the Prairie Band Reservation. The American Heart Association had the Walk with Ease program, and that was a 30-minute walk program that we did twice a week out there, and that kind of held me accountable, and that's how I started the walking. And my granddaughter, like I say, still walks me every day. I told her about it, and she helped me read the book, and we started a walking program after dinner, and I've kept up with that. There's a strength training class. You know, I'm all about trying to get healthy. I've got a lot of years to live, and I want to enjoy it to the best that I can, so I do everything that I can.
Absolutely. Great. Good job. And would you like to see any changes to any of that? I mean, essentially, what I am hoping is we can come up with new ideas on how to move forward also. Is there something that you wished that would happen differently or better?
I guess if my provider could probably have spent more time with me, would have been the main thing, because she sees me more often. But like I say, the stuff that I received from Matt really put me in the right direction. And you know, I lost 170 pounds on his diet, and I was able to have both my knees done, and that's what really what I needed.
That's good. That's amazing.
Yeah, you know, so if I'd have probably been able to spend a lot more time with my provider, you know, I think that, you know, but you know, like I say, Matt was really a lot of help.
Mm-hmm. Yeah.
No, thank you so much for the praise, but it's all you. We give you the blueprint, you just build the house. It was all you.
Okay, well, you supplied the lumber.
So Angela, back to diets, and the word diet and fad diets. Can you comment on fad diets and how effective they might be or may not be?
So generally, when I hear fad diets, in my mind, the first thing I think is this probably isn't going to be sustainable. So any kind of diet that is cutting out complete food groups or is causing a lot of restrictions, the question I always ask people to ask themselves is this something I can stick to in the long term? If it's not something that you can stick to in the long term, then it's not something that you want to do in the short term. Because generally, if it's something that we can only do for a couple of weeks, any potential weight loss or benefit or anything like that you may be getting from that diet is not something that you're going to see in the long term. Because once you can no longer do that and you're miserable and you're tired and you just give up, then the weight is all going to come back on. Anything is going to go back to where it was before. And then generally we feel like we've failed. It's much better to kind of look at your diet and where it's at now and kind of say, okay, what realistically can I do to make changes that may move me to eating in a way that may be a little bit more healthy, better for me, versus what massive thing that I can do that I heard online, this person lost a ton of weight on, and do this for, you know, a couple of weeks and then can't do it anymore, and then you're frustrated. And a lot of times we take that out on ourselves then. We're like, I have failed. I can't do this. When really the diet has failed. It's not realistic. It's not something that most people, or if anyone, can do, at least for any long period of time.
Makes a lot of sense. It's like, yeah, massive weight loss in a short amount of time. It's just not sustainable. It's been shown over and over and over again through different, you know, fad diets, as they call them. So does, Matthew, does your program, Prairie Band program, have diabetes self-management and education curriculum?
We do not. We offered it before COVID, but after COVID, we no longer offer it. We found that during the classes, the same attendance and the results weren't there, which is great. Having the classes was wonderful, but what we learned is having that one-on-one session was even better. Having the results after those one-on-one sessions to get to know the patient. Community settings are wonderful. The classes are great because it gets everybody in, and we talk about recipes, what we could do different, the stressors that are going on in life. Yeah, that's pretty much it. Plain and simple.
Mm-hmm. Yes, we've just started up a post-COVID diabetes self-management and education curriculum at Haskell. Angela teaches a couple of modules, I teach a couple of modules, and then we have a medication manager, a behavioral health specialist, and then a diabetes case manager. She's an RN. So we kind of tag team the entire course, and it seems like we're you know, reaching our patients and getting them some good advice, and so that's another thing that we're pushing at Haskell right now is getting people in, and it's during the lunch hour so they can take off time from work, and we allow them to bring their kids if they want to, just, you know, make it an hour. And Angela's our resident chef also, so she puts together a healthy, nutritious meal. The last week's was bison burgers and sweet potato fries. And I was just telling her that this was the first time I've had bison twice within 1 week. But it's good. And every week we have something new on the menu, and it's a very healthy, nutritious meal. And we really like getting people together because it allows them to have a discussion. It's not like nobody stands up in front of the room and lectures. We sit around a table, we have a meal at the same time, and we just talk about what might be going on, but we also cover a curriculum also. So, and it's educational. They learn more and more about, you know, diabetes and how it's affecting their bodies, and how they can, you know, overcome some of the obstacles that they face. So I think it's really important to have that education outlet there for them. And they get to interact with each other.
Uh-huh.
It's great. Let's see, so Rhonda, were you a vegetable eater growing up?
No,
No?
we were canned food. But since then, we live out on a farm, so we have a garden, and our garden flourished this year. So we have fresh vegetables all the time. My granddaughters have grown up on fresh vegetables.
Oh, that's great.
I always believe that each generation should be brought up better than the generation before. So I do feel that my granddaughters will have fresh vegetables in their life a lot more than we have.
So do you like fresh vegetables?
Oh, yes.
Yeah?
I never thought I would like zucchini, but my daughter-in-law makes it, and I eat it, and It's really good.
So you did not grow up eating fresh vegetables regularly?
No, all of our stuff was canned food, canned vegetables.
Is that commodities or?
Yeah, through
Yeah.
commodities. And yeah, so I never, even when I had my kids, I just bought canned foods. Scooted right on past the fresh vegetables when I was grocery shopping. And then when I moved in with my son and his wife, she grew up on a farm, so she made everything fresh. And like I say, the first time she fried up some zucchini, I was like, ew, I'm gonna pass on that. And my son said, just try it, it's really good. And sure enough, I tried it and it was good. And every time she cooks it up, I eat it with them. But yeah, it's we have fresh vegetables all the time now.
So was that an easy transition?
Not in the beginning, it wasn't. But since I got on the diet and knew I had to have fresh vegetables, it's became easy. So,
Nice.
And my
Nice.
granddaughters, they grew up on it, so it wasn't hard for them. They really don't have canned vegetables.
Yeah, I ate a lot of commodities growing up too, as you can probably tell, but it's definitely, the commodities, they tend to have a lot of fat and a lot of carbohydrates and not a lot of nutritious meals or nutritious content, which is unfortunate. And so many of the people in our communities rely on that just for sustenance, and so hopefully at some point in the future, I think they're getting better since I was a kid, and since, I think they have fresh meats now and some fresh vegetables, but for the most part, there's still all that canned, salty food. It's just not that great for us. Let's see. Do you have any barriers or obstacles now that you're being challenged with?
No, not really. Like I say, I have a stationary bike, so if it's too cold or too hot outside, and we can't walk, my granddaughter makes me get on that stationary bike, and she'll sit there on her tablet and put the timer on, and yeah, I still got to do 30 minutes on that bike, so no, but I don't mind it now. Like I say, the diet and the exercise, it's just a way of life now. And I've went down from 1,800 calories to the 1,500 calories, and really I didn't even notice the change. I no longer race to McDonald's on payday. That was kind of hard, but it worked out okay. But yeah, it's just a way of life now, and I'm really glad that I'm on the diet. I don't really miss anything.
Excellent. Thank you. So, with the few minutes remaining, I'd like to open it up to the audience. If anybody in the audience has any questions for our panelists or for myself, I'd be more than happy to. Yes.
Yeah, I just wanted to make a comment. I really miss going to your clinic. I don't believe we've met, but I did utilize the diabetes program there at Haskell Indian Health for years.
Okay.
Before I moved out this way. But I loved the whole team approach. It made me feel really like they're taking it serious. They're taking me serious. And of course, I logged my numbers like daily
Oh, that's great.
because I couldn't believe I was doing almost 4 miles a day speed walking, and I just could not get my numbers down enough, to the point that I had to get on Ozempic. And then I've got friends all over, the United States, and, a lot of people use their insurance with their IHS clinic, and they're all being put on Ozempic. So I'm wondering, when will we see numbers, data that we can synthesize in order to find out how this is helping our community? Because, you know, I don't like being on Ozempic, and I'm keeping myself at 0.5 dosage. I know people that are already at 2, and I don't want to go there. So, you know, I'm really like trying to be very cognizant and careful about, you know, what that data is going to look like for us. You know, we don't really know a whole lot about it.
Very true. It's pretty new on the market, and it's you know, a new thing, a new treatment plan.
So Damon, I can actually speak on ours.
Absolutely.
So we actually have a great data coordinator, which is Justine back here. And she could spout off numbers like crazy with our data that we collect, because we, first initial visit, we collect A1C, we collect weight, we collect cholesterol, all of that. And then we collect that over time. And the studies show that we've been running, and we have a great relationship with Novo Nordisk, and they visit us monthly because our data is so good. We're talking about a loss of 26 pounds per patient within 6 months, A1C reduction of 1.6 in 6 months. And that's just you doing what you do best and the medication doing its job too. And we're seeing a lot of great data from it. Yeah, absolutely.
That's awesome.
That's where I go now. So
Yeah. Yeah, stop by.
Yeah, we're not quite as aggressive as they are on collecting that data. We do an audit, a diabetes audit once a year, and that's basically the data that we go off of. And so we do our planning off of that for the following year. And that's on a calendar year. So at the end of this year, we should probably have our first round of data for our Ozempic. Yes, sir.
Have you guys seen any? What's your opinion on intermittent fasting? Have you seen any benefits as far as diabetes?
Do you want to go first or me?
It doesn't matter.
Yeah, I'll speak on my behalf. So I'm a fan of intermittent fasting. It's been around since the beginning of time, but now we don't have to hunt for our food, right? So it's crazy to think of it this way. This is how my brain works, is that we have to be on medication to help us stop eating, right? Because we live in a time of plenty. I'm totally fine with it as long as it's okay with your provider and the medications that you're on won't affect your fasting. That's my personal opinion. Now, as a registered dietitian, she might have different.
I would say my opinion is somewhat similar, but I think that a line has to be drawn as well as what does intermittent fasting mean to you. Intermittent fasting can mean different things to different people. I have some people that say they want to do intermittent fasting and they are doing like an 8-hour eating window and a 16-hour fast. That I'm generally okay with. However, I have other people that are doing intermittent fasting and they're trying to do like 1 hour of eating and 23 hours of fasting. That I'm not actually okay with. I will tell you, as far as the research I have looked at with intermittent fasting and the data that I have kind of seen out there, it does seem to look like it is a little bit more effective in men than it is in women. I will also tell you, although not generally what people want to do with their eating window, research tends to support an earlier eating window versus a later eating window. So if you're doing like a 16-8, eating between like 9 a.m. and 5 p.m., the research supports that a lot better than like a 2 p.m. to a 10 p.m., which I would say is generally more in line what people tell me they want to do. But I would say there can be some, and I would say as well, like even doing like a 12 hours, like a 12 and 12, because some people are eating, they'll eat their first meal at 5, 6 in the morning, and then they may be snacking at, 10, 11, 12 o'clock at night. In that circumstance, kind of increasing that fasting window may be beneficial for someone with diabetes.
Now, I do have another question. So fasting. A lot of people don't really know what fasting is. I get a lot of patients that say, what is fasting? Can you go into detail of like what fasting is? Like if I put creamer in my coffee, does that break my fast?
So, I mean, I would say technically yes. Now, if you look at what people say out there, there's a lot of different kind of restrictions on what people would consider what breaks your fast and what doesn't. From the basic guidelines of fasting, if you're doing something that other than water, or black coffee or tea without any sugar in it, you're gonna be breaking your fast. Now, some people would say, well, if I just put like a small splash of creamer in my coffee, in the grand scheme of things, that's so little, is it really gonna make much of a difference? I would say maybe, maybe not. Probably not a huge difference, but technically you wouldn't be fasting if you're doing that. I would say same thing with think like when you're doing fasting labs. Before fasting labs, you can have water, you can have black coffee, but you can't have like creamer in your coffee, you can't have sugar in your coffee. You would no longer be considered as having fasting labs.
Excellent answer. Thank you. So I guess if there are no more questions, if we could give our panelists a good round of applause for excellent advice.
Sorry to interrupt. Could we give Rhonda like a standing ovation for all of her hard work and everything that she's done? Like, she is the model.